have not very important topic, but one or two things from this topics are very important because they often ask in your PG entrance exam. So we have a 40-year-old male patient today who has history of fall on outstretched hand. And after the fall, he has pain and swelling of the elbow along with the restricted elbow movement. So this is the mechanism of injury, how the patient sustained the injury. So after the injury, patient is having pain and swelling of the elbow and restricted elbow. So it's a elbow injury. So what can it be? So we have a lot of different types of elbows injuries. So here today we are discussing about the elbow dislocation. So elbow is the third common joint to dislocate in adults. So first joint to dislocate in adult is shoulder, followed by patella, followed by uh, elbow, whereas it is one of the common joint to get dislocated in children. So in adult, it is the third common joint. So it may be a simple dislocation where the joint uh, lose contact with each other, or it may be a complex one where the dislocation is associated with the fracture or injury to the surrounding soft tissue structure. So we have either a simple dislocation or a complex dislocation. So what are the structure in and around the elbow which are very important? So three nerves are there. So if you see, this is radius, so it is on lateral side. This is ulnar, this is on medial side. So medial side posterior to the medial epicondyle, we have ulnar nerve. Then just anterior to the distal humerus on the lateral side is the radial nerve, and anterior to is the medial nerve. And this is your brachial artery. So these are the neurovascular structures which are in close contact with the elbow joint. So either they are quite anterior or little posterior, and they are very vulnerable to sustain injury or damage when you have patient have elbow dislocation. So before knowing the dislocation of elbow, we need to know what are the structures which give stability to the elbow. So first thing is this is ulna and the humerus. So this is something like a round structures inside the soft kit. So it is inherently stable. So it's not easily subluxate or dislocate unless they have very significant injury. And this presence of this coronite process they give additional stability. So we have inbuilt stability of humero-ulnar joint. Then the radial head. So the radial head also gives stability. It won't allow the collapse or lateral deviation of elbow. Then third is we have on the medial side, medial collateral ligament that prevent elbow deviating laterally. On the lateral side, we have lateral collateral ligament which prevent elbow going medially. So we have inbuilt structure of the humero-ulnar joint in which the coronite plays important role in giving stability to the elbow joint. So this point is very important because sometimes in the complex elbow dislocations, we have injury to any of these stabilizing factors, this one, the stabilizing structures. So what are the types of dislocations? So dislocations, the proximal bone that is humerus, we consider it as stable, whereas ulna, we consider it as the unstable. So this is stationary, this is moving in relation to the humerus. So it may move posteriorly. So it's a posterior dislocation. Or this ulna move anteriorly, anterior dislocation. Sometimes it may go lateral, medial. It's a medial and lateral dislocation. So if you see here in the lateral view, it's a posterior dislocation. Here it's moving anteriorly, anterior dislocation. It's moving on the radial side, that is lateral dislocation, medial dislocation, and sometimes radius will go one way, ulna will go one way. So this type of dislocation is called as divergent type. So just one point to remember here is humerus, we consider it as a stable bone, and the ulna, it moves in relation with the humerus either anteriorly, posteriorly, medial or lateral or in divergent way. What is the presentation? So a patient will have history of trauma, then deformity following the trauma, then this above the olecranon, you feel the disruption because of loss of tricep contact. Then elbow is very restricted movement of the elbow with bruises over the elbow joint. So this is how the patient presents. And neurovascular, all the three nerves, median nerve, ulnar nerve, and radial nerve are vulnerable to sustain injury along with the brachial artery. Diagnosis as common in any orthopedic problem, X-ray. You need to take both AP and lateral view, where you can see the humerus olecranon lying posterior to the distal end of the humerus. And if you are suspecting any fracture either of olecranon, either of coronoid or humerus, and you are still having doubt, you can take CT scan to plan accordingly. What is the treatment you can plan after taking the CT scan? Then once you have diagnosed, how will you treat? So most of the time, elbow can be reduced by close reduction. So we do it under general anesthesia because it's a very painful procedure, or so brachial plexus block or general anesthesia. If patient is having some problem with the reduction, when we may need to go for open reduction. So the two common indication of open reduction is when you try to reduce it, but you are not getting a concentric reduction. Concentric reduction means it should be a uniform reduction. If you are feeling like non-concentric, it's a eccentric like this with the empty space here, then it indicates that there is something here which is not allowing it to move inside. So in such cases, you need to go for open reduction and clear the olecranon fossa. Or sometimes you may find some osteochondral fragment, as how you see here. If you find this osteochondral fracture, you can't remove it without opening the joint. So for removing the osteochondral fragment also, you need to go for open reduction. So indication of open reduction is non-concentric reduction or patient who have osteochondral fragments. Then depending on the associated injury, as I told you before, there may be either collateral ligament injury, which is stabilizer, either we have radial head injury, or you may have coronoid injury, coronoid fracture. So depending on the which bone affected, we may need to go for reconstruction. So either reconstruction of collateral ligament or fixation of the coronoid fracture, or sometimes when there is a radius fracture, we need to do something for the fracture of the radius. This is how we treat the elbow dislocation. So what are the complications? At this it involves the joints, so there is high risk of developing stiffness. Patient may have collateral damage. So if patient has collateral damage, they may have instability. And patient may develop arthritis due to the cartilage damage, neurovascular, as I told, brachial artery and the nerves are very close. Patient may have compartment syndrome, articular surface damage, and recurrent stability. And they may have sometimes myositis ossificans. And if they're not attended properly, they may have contracture in futures. So this is all about acute elbow dislocation. So there are three conditions which are not very important, but quite seen in relation with elbow dislocation. One is neglected elbow dislocation. Neglected elbow dislocation is patient has dislocation, but he doesn't present to you, did not come to emergency immediately after. He may come after 3 weeks or more than 3 weeks. If that is the case, what happens is on the posterior aspect of the olecranon, we have attachment of the triceps. So due to movement of the olecranon away from this tricep gets shortened. So there is shortening of the triceps. This triceps gets shortened. So in these cases, we can't get the close reduction. So we need to do open reduction, and along with the open reduction, we need to do one more procedure, that is lengthening of the triceps. So if the patient comes to you with neglected elbow dislocation, sometimes we may need to go for open reduction and triceps lengthening also if we are not getting the reduction properly. Then there is one entity called as terrible triad of elbow. What is terrible triad of elbow is there is elbow dislocation along with the radial head fracture. So a radial head is fractured here, and elbow is dislocated outside, and injury to the coronoid. So radial head or neck fracture, elbow dislocation, and coronoid fracture. This is called as terrible triad of elbow. This point is often asked in your PG entrance examination. What is terrible triad of elbow? We have one more terrible triad of knee joint. We'll learn about it when we are doing the knee injuries. Then the third one, it's also an important thing, is Essex Lopresti lesion. This again we are going to came across when we are learning about the radial head dislocation, or we are learning about the forearm fracture. What is Essex Lopresti is, here we have the radial head fracture, and we have the interosseous membrane in between the radius and ulna. So due to the radial head fracture, what happens is the radius moves up. So there is damage to the interosseous membrane. When there is damage, whole radius will move up and patient will have distal radioulnar joint disruption. So the combination of radial head fracture, interosseous membrane damage, and distal radioulnar joint disruption, we call it as Essex Lopresti region. So here, what are the things you need to remember? There is acute elbow dislocation, there is neglected elbow dislocation, terrible triad of elbow, and Essex Lopresti legion. So this is all about today's class. Please like, share, and subscribe to my channel, and keep posting the comments so that we can improve in next presentation. Thank you.